So let's talk about the sodium channel now. Okay, so there's three different classes or subclasses of the sodium channel blocker, and really the difference between these agents all basically look at the membrane repolarization shape of this curve. And so the class 1A agents, there's relatively moderate sodium channel blocking, but there is a kind of a prolonged repolarization. The class 1B agents, there's relatively mild sodium channel block with a shortened repolarization, and the class 1C agents basically show a marked sodium channel blockade and no change in the repolarization. So really it comes down to kind of, the kinetics and how they relate to their ability to change both the sodium channel itself and their effect on repolarization of the SA node. All right. And so if you look at the degree of transmembrane potential, basically comparing drug to non-drug, you can see that the transmembrane potential is going to shift. Okay, and these premature stimuli basically get organized. And so the kind of the analogy is like herding cats. So the arrhythmia is kind of like herding cats, which is damn near impossible. But when you put the drug on board, it's kind of like herding, I don't know, what's an easy animal to herd? Sheep, right? Sheep or goats. Sheep, they lend themselves to be herded, which is why we've been doing it for thousands of years. And so this is what this electrophys basically kind of looks like. And so you get all these different circus movements. And what this does, these drugs do, is that they essentially restore order to some of these really excitable tissues that are completely out of focus. And so now we'll look at the sodium channel in a little bit more detail.
Okay. Your class 1 channels, there are actually 3 different types of these. They all block fast sodium channels, and so they all prolong this phase 0 increase here. And that slows action potential propagation frequently, particularly in the case of class 2B. The effects tend to be preferential on disease tissue, which is very helpful. Okay? The idea is, once again, to treat reentrant arrhythmias with these things. If you have slowed propagation up this beta pathway at all, the thinking is that if you block some sodium channels, you might be able to stop that propagation altogether and just keep it from taking place. All right? So if it's already diseased, it already doesn't want to propagate action potentials, you just block it completely. That's the theory behind blocking the sodium channels themselves. It turns out that these do have an effect that I don't think is very well understood on the pacemaker channel and on automaticity, and they slow the rise in phase 4, and they therefore can be effective for supraventricular arrhythmias, where you want to increase that threshold and decrease that slope and slow automaticity. And this might make some sense to you in that, I said phase 0 is carried by calcium in AV node and SA node. That's not really true in Purkinje fibers and fibers in the conduction pathway. They have sodium channels. So the key to decreasing automaticity in those tissues may be targeting sodium channels and allowing the calcium channels to go ahead and be okay. So you can get a decrease in automaticity, and it can be targeted to ectopic foci, where the sodium channels are more involved. Okay? Go ahead.
So this doesn't really change with the SA?
Well, the sodium channel blockade component won't change the SA node or the AV node. If you're having an effect on pacemaker cells, it will. And it'll decrease this phase 4 slope, and it'll slow the depolarization, and it'll slow the heart rate. Okay? So, but that's not because of effects on fast sodium channels. It's because of an effect on the pacemaker channel. But by having an additional effect on fast sodium channels, you can have an additional effect on the ectopic foci. Okay? At least in theory. Okay? Make sense? No? The pacemaker channels are not fast sodium channels. They're different, right? They're letting sodium in and potassium out. They're different channels. So we have one effect due to an effect on pacemaker channels. where we're slowing the depolarization in phase 4, and that slows your heart rate. Okay? Make sense? All right, now we have another effect because these are actually targeted toward the fast sodium channel. The sodium channel that mediates phase 4 in Purkinje fiber, phase 0, in Purkinje fibers and in ventricular cells, okay, and in atrial cells, okay? And by blocking some of those sodium channels, we make the threshold potential less negative in those tissues, particularly in this case, it can be handy in the Purkinje fibers. If you've got an ectopic focus, okay, where your phase 4 is rising and activating sodium channels to some extent, all right? Blocking those fast sodium channels can have an additional benefit there. And so they can make these particularly handy for decreasing automaticity in tissues of the conduction pathway. Did that help? Good. All right. So, decrease phase 0 upstroke, decrease reentry, and here's your AV nodal effect right here, the effect on phase 4 in all tissues that have automaticity because of the blockage of a pacemaker channel. Okay. In the class of the 1As, we have an additional effect. Class 1A, in addition to being sodium channel blockers, block potassium channels. So they will prolong your action potential plateau, and they will increase the refractory period in the alpha branch, where we want to keep that depolarization going for as long as we can, so we can stay as refractory as long as we can, so that when our retrograde propagation up the beta branch hits the alpha branch, it'll still be depolarized and it'll still be in refractory period. So the class 1As are a combination of class 1 sodium channel blocker and class 3 potassium channel blocker. And they would make, in theory, it would make them particularly good for a reentrant arrhythmia. Okay? Thanks.
Thanks. So again, just as Dr. Shannon alluded to, the classes are becoming more and more promiscuous, I think is a good word, because they're not actually following the Vaughan-Williams classification, which is, we still use it. I don't think there's any other way to organize it. There's a new article relatively recently in one of the cardiology journals calling for the abolishment of the Vaughan-Williams and a new classification scheme. It hasn't been adopted yet, which is why I didn't teach it. But I agree with them. It doesn't really make sense. So let's kind of look at these class 1 agents, which are basically sodium channel blockers. The differences are basically addressed in terms of the potency and their ability to kind of slow the conduction velocity. Okay, and so the 1C agents are the most potent, okay, in terms of their clinical or physiologic outcomes. The 1B agents offer the least potency, all right, and the 1A agents are intermediate in terms of their potency. Obviously, when Vaughan-Williams sat down and classified these drugs, A, B, and C were not basically based on potency. They were based on, the refractory period. And so they were really looking at kind of the old-fashioned kind of patch clamp physiology in terms of what the cells look like ex vivo. So what are these sodium channel blocking 1A agents? Quinidine. Okay, quinidine will block the activated sodium channel. It'll slow that upstroke of sodium and it'll prolong that QRS interval. We will use quinidine to maintain normal sinus rhythm in patients that have atrial flutter or atrial fibrillation. Based on pharmacokinetics and pharmacodynamics, the nuances to quinidine are listed here. Side effects and toxicity: GI, nausea, diarrhea, vomiting in mostly a third of the patients. Headache and dizziness are associated with toxicity. As we as we demonstrated, quinidine is not a pleasant drug to be on, to say the least, but, it definitely will block that 1A sodium, or that sodium channel from the 1A class. Probably another 1A agent that's a little bit more clinically useful would be procainamide. It's really effective in most atrial and ventricular arrhythmias, and we don't really use this long term. So you don't really see patients on procainamide for 6 weeks. Okay, it'll be kind of a short-term use of a drug during acute MI as a secondary intervention to lidocaine. Okay, so what does that look like? Well, the patient walks in with an MI. They're going to be placed on all those drugs that we talked about last week. Okay, and in the back of your mind, as the clinician, you might be worried about an arrhythmia starting at this point, right? Because at this point, you don't know how much necrotic myocardium exists. Is this a mild heart attack or is this a major heart attack? Okay, and so how do you assess that? I guess we'll review pathology as well. How do you know if the patient had a mild or a major heart attack? What types of tools are you measuring? Well, one thing you can look at is the left ventricular ejection fraction. Okay, that'll tell you how much blood is being pumped out per unit time. And the other thing that you can look at is maybe some type of imaging on the heart, whether it be ultrasound, CT, or some type of structural measurements. And you want to look to see if that ventricular muscle's gotten thicker due to hypertrophy. So all of those measurements would kind of feed into that. So this procainamide, essentially what you would be doing, what you'd be using it second to lidocaine, would be kind of, preventing some of these circus movements that might have come about through this dramatic myocardial infarct of cell death. Okay. Also structurally, there will be some ganglion blocking ability to procainamide, but, again, the patient's not going to be on it for weeks. They might be on it for a couple hours. All right. Various routes of administration, both hepatic and renal metabolism or elimination. Long-term therapy, and this is why patients don't take these drugs for very long, is associated with a lupus-like syndrome, which is reversible when the patient stops the drug. Okay. Other 1A agents include disopyramide. These are mostly for ventricular arrhythmias, at least here in the U.S. If it's used for an atrial type of arrhythmia, you have to use a drug that slows the AV conduction velocity with it, which we'll talk about shortly. There's also anti-muscarinic effects, much more so than quinidine, so it starts to behave like atropine, and the dose guideline is listed there. So a lot of different nuances to some of these drugs. Disopyramidine is a negative inotropic effect on the heart, specifically on the ventricular myocardium. When you use this drug, you can actually precipitate heart failure, okay, in naive patients or patients with pre-existing left ventricular depression. So, as you're kind of assessing the patient, you have to kind of look at left ventricular ejection fraction, which we'll talk about tomorrow, to see if heart failure is becoming manifested. And of course, if it is, this drug is completely contraindicated in heart failure. So even though they may have an arrhythmia, if they've got an arrhythmia and heart failure because of an acute MI, this drug is a no-no. Right? And so really the class 1A agents, quinidine, procainamide, and disopyramidine, are listed here. Okay? And this is just kind of looking at the differences in terms of the clinical pharmacology. All right. Here's another summary chart looking at the electrophysiologic effects. And, in terms of their ability to decrease or depress conduction velocity, they're all essentially equal. And according to their ability to increase the refractory period, they're essentially equal as well. Okay? Nuances come out here, but essentially these drugs are pretty much the same across the board. Okay? So that kind of brings us to the 1B agents, and these are the 1B agents that are associated with the open calcium channel, or open sodium channel.
Yeah, I'm going to talk about that because it's wrong. And it's right in your notes, thank goodness. I made that correction this year. I didn't correct the slide. Let's talk a little bit about why you'd want to shorten the action potential to begin with. Because we just got done talking about the fact that lengthening is good with the type 1As. You guys remember long QT syndrome from last year, and we talked about the fact that if you lengthen the action potential plateau, it can lead to these early after depolarizations, or EADs, and that can cause triggered arrhythmias, which Dr. Shaw mentioned a minute ago, okay? As it turns out, at least in MI, and maybe one or two other diseases, you lengthen the action potential plateau. And the reason isn't because of a mutation in a potassium channel or anything like that. It's got to do with the fact that all of a sudden, these sodium channels that are supposed to activate rapidly and inactivate rapidly don't completely inactivate, okay? For some reason, they have a tendency to want to open during that plateau phase instead of inactivating completely, all right? It's still an area of active investigation. It probably has something to do with calmodulin-independent protein kinase activity, which you don't need to know. But it seems to happen. And so what you get is what they call a late sodium current. It's not a very high percentage of these channels. If it was, you'd die because there are so many sodium channels. But it's enough to make a difference. So in addition to your calcium current and your sodium-calcium exchanger during phase 2, you also have this extra sodium influx. So that makes your voltage hang around more and stay depolarized longer, and it lengthens this action potential plateau, and that can lead to EADs, all right? So these drugs are targeted toward that late current and shortening that action potential plateau so you're less likely to get these triggered arrhythmias, all right? And the way they work, it says that they're open channel blockers. That was my bad. That was my misconception. In fact, these channels are not open for very long, and the vast majority close and inactivate really fast, and they stay inactivated during that plateau phase. And so these drugs actually bind both the open channel and the inactivated channel. And so they're bound all the way through this action potential, and then upon repolarization, they unbind, and they allow the channel to open again. But they're bound during the action potential plateau, and they prevent these late sodium channels from reopening, okay? And so they prevent this lengthening of the action potential plateau. And so that's their mechanism of action. In fact, they're mostly bound to inactivated channels because this opening is so brief, there's almost no time for them to bind. And so there's only a very minor effect upon the upstroke of the action potential. You saw that earlier in Dr. Berderic's slide. But the late sodium current is inhibited enough to shorten this action potential plateau. And so that's in theory how these things work, all right? So both open channels and inactivated, they stay bound during the entire plateau. They unbind at these negative potentials, and theoretically, they help you with these triggered action potentials. Okay?
Then as we go through,
I should have mentioned, I'm sorry,
Go
I
ahead.
should have mentioned that the binding is increased when you're acidotic, and when you've got high potassium, and of course when you're depolarizing a lot, you're staying depolarized, you're allowing more time to bind. And so these are all conditions that are favored during MI or during an arrhythmia. So it's more likely to bind during an arrhythmia as well, and that makes it effective in diseased tissue, not so effective in normal tissue, which is what you want. You want it targeted toward the diseased areas. Sorry about
no,
that.
that's good. That was a good segue because that's what I was going to say. Lidocaine, when you guys have maybe used, or had lidocaine injected to you for like dental procedures, right? A small amount of lidocaine. When it's in an acidic environment, it actually kind of changes the pharmacokinetic profile, so more of that becomes basically available. And so these drugs, when they're exposed to hypoxic or acidic environments, which would happen, both in terms of, the gum tissue itself, but also in terms of an acute MI, they actually work better. So you get a really good diffusion of this drug through the acidic tissues. And so lidocaine is probably the one that's most clinically relevant, especially during the acute phases of MI, and it's a 1B agent, of course. And so It'll block both the inactive and the active sodium channel with really fast kinetics. And the more acidic the environment, the faster the kinetics. That inactive state block is going to ensure that there's a large effect on cells with really, really long action potentials, and those would be the Purkinje fibers, the ventricular myocardial cells themselves, and then eventually the atrial cells. So where do we see them? They're used to basically abolish arrhythmias that are occurring during the acute MI. Okay, so in terms of the MI, you'll see STEMI, you'll see ST segment elevation on the EKG, okay, but you'll also see typically ventricular tachycardia along with it. And so lidocaine would be given IV, okay, and it will stop that ventricular fibrillation. And so if you don't stop it, then this MI now progresses to cardiac arrest, right? So we're basically in this zone of the patient's physically lying there, STEMI is occurring, okay, and they're tachycardic, and the ventricular muscle is just going crazy, all right? And so again, this is given IV. Out of all the 1B agents, lidocaine is the least cardiotoxic, okay, which is why it's so prevalent. It may precipitate hypotension, okay, but again, these patients are typically, this is during the heart attack, this is kind of the least of your worries. So very, very large boluses of this, especially in patients that have pre-existing heart failure. So maybe if this is a recurrent STEMI, this is their second heart attack, as you'll soon learn tomorrow, they'll already be in stage 2 heart failure. Okay, there will be some neurologic effects, but again, this is this isn't a drug that they're going to be on for 6 days. They'll be on it for 5 or 6 hours until they're stabilized. There will be some maybe neurologic effects. So anywhere from lightheadedness to maybe hearing disturbances, all the way to convulsions. So the side effect profile is quite wide. And it's all stemming from sodium channel blockade. There's extensive first pass metabolism, which is why we don't give it orally. Of course, we would like to have it may have its major effect at the time of the MI. So again, we prefer the IV, but you can see loading doses to basically have the more potent outcome. Higher doses can be tolerated in patients with an acute MI, and that's typically what is seen clinically. Other sodium channel 1B agents include mexiletine, it's a congener of lidocaine, and it avoids the first pass hepatic metabolism, and so you can give it orally. This can be used to terminate ventricular arrhythmias. Of course, there will be some CNS side effects as well. So this would be kind of more for the kind of persistent arrhythmias that would occur, kind of in like a non-emergent situation, but still would need to be clinically addressed. Okay. Phenytoin, don't worry about. We'll talk about phenytoin later. This is more of a CNS type drug, but it does have some anti-arrhythmic ability, and a lot of this is kind of used off-label. So, it is technically a 1B agent, but you see it more used in the CNS diseases. And again, some more summary slides of looking at these. And this is coming from a cardiac review, an anti-arrhythmic review article that was published a couple of years ago. All right. So now as we go through, now we're going to talk about the class 1C sodium channel blockers.
Don't sit down, this won't take long. In addition to all the normal sodium channel effects, the 1C increased the refractory period in the AV node. So that means it widens this action potential and keeps it depolarized longer, which means if you have a supraventricular arrhythmia like atrial fibrillation or something like that, it makes it harder for those action potentials to get through the AV node and excite the ventricle. So they can be effective for these kinds of arrhythmias. Unfortunately, mechanism unknown. Okay, so take that for what it's worth. It does it, and we can all be grateful, I guess. But nobody knows yet exactly how that works. Okay, that was pretty short.
Yeah, that's the punchline. Okay. And the main drug here is flecainide. And so, we think it blocks sodium-potassium channels, and the kinetics are relatively slow. It doesn't really affect the action potential of the QT interval. So what kind of patients would get this? A patient with essentially a normal heart that has atrial arrhythmia. So remember, atrial is supraventricular. And it'll kind of suppress the premature ventricular contraction. So I always think of this particular drug as kind of like the stoplight. And so if, if the atrium is the point where all the traffic exists, and the ventricle is kind of like the country road, the main thing that's preventing the traffic from getting to the open country road is the stoplight, okay? And of course in Chicago there's many stoplights, but there's just one, okay? And so these drugs are great, or this drug is great for some of those atrial arrhythmias that are kind of driving or pushing some of the other cardiac pathologies. Another 1C agent is propafol. And again, this is structurally similar to propranolol, okay, so there is some beta blocking ability, and same indication, supraventricular, also known as atrial arrhythmias. The spectrum of action is kind of similar to quinidine in terms of its sodium channel blocking kinetics. Patients will complain of a metallic taste and of course constipation. Those are the two main common side effects, but arrhythmias can be exacerbated. And so, propafol can be used with severe caution. Morphazine, this is an old drug. This will only be available probably in like the Kazakhstan or some former USSR republics. We teach it just because it was cool from a kinetic standpoint, but they took this drug off the market, so don't worry about morphazine. He's gone. Okay, and so really it's just flecainide and propafol. Okay, and different elimination and approach. So if you're looking at specific nuances of patients, there's really just two drugs to kind of choose from. Same here, summary. Okay. And so one of the ways in which they've differentiated some of these drugs are, which drugs have the most potassium blocking and which drugs have the most sodium channel blocking. And so this is kind of unique, or I like this slide. The class 1B agents have the highest degree of sodium blocking and the lowest degree of potassium blocking. In contrast, the class 3 agents, of course, have the highest potassium blocking ability and practically zero sodium channel blocking ability. And in between are this no man's land of class 1A and class 1C agents, which have, obviously potassium channel blocking, but also sodium channel blocking as well. So this is where kind of they overlap. And that just kind of puts things into kind of visual perspective. And of course, there's examples of each on the bottom axis.